Good afternoon, everyone. Good afternoon from the UK. It's just 2:04, so we're going to be admitting people as we come along, but we'll admit people as we go as we go through. Welcome to the GLEFA Trauma Informed Special Interest Group presentation that we're going to have this afternoon. I cannot tell you how excited we are here around having Wendy Ellis with us. It's been a long time coming. We've tried to get Wendy a few times, and we've managed to do it today. For those of you who don't know me, my name's Justin Srivastava. Up until just over a year ago, I was a serving police superintendent here in the United Kingdom, and I also worked for the National Police Chiefs Council on trauma-informed practice, and did a lot of work around serious violence. And I'm the board member for GLEFA, for the Trauma-Informed Special Interest Group, which you're going to hear about a little bit more as we talk today. Whilst we're here, I'm going to make two shameless plugs. One's for GLEFA. So for those of you who don't know what GLEFA is, and you're thinking, what's it all about? It stands for the Global Law Enforcement and Public Health Association. I've been with them for over 10 years now, and we bring together from all over the world a look at how we can work together around improving health, safety, social justice, particularly around bringing law enforcement and public health together. Because for many of us, you think, well, do they really work together? Are these really dealing with the same things? And the reality is, when you look at the drivers of crime and you look at the drivers of other social determinants of the health inequalities, they're all the same. So actually, we're all working together around the same issues. So for those of you who don't know about GLEFA or would like to know more, there is in the chat bar there a link to GLEFA, and we'd love you to join and become part of the GLEFA global community. We're currently very active in Australia, New Zealand, America, Canada, Europe, some parts of Africa, as well as Asia. So we'd like to expand that into a total global piece for GLEFA. And the second bit I'd like to remind folk of is our conference. Every year we have a conference in different parts of the world. This year, in 2025, we had our conference in Ottawa. We've previously had them in Philadelphia, in Holland, in Edinburgh, in Scotland. And next year, you can see on the PowerPoint slide there, we've got Law Enforcement and Public Health, the 8th International Conference in Leeds here in the UK. So there's a link there. You can use the QR code and get yourself registered. It looks like it's going to be a really, really, really good agenda, and we've got a lot of people from all over the world already talking about coming. So we'd be really, really keen to have everybody on the call there for that conference. Couple of things we're going to be talking. We've got 2 hour slot. If you could put in the chat bar who you are, where you're from, and also what country you're from, we'd be really grateful, as well as what organisation you're from, and that would help both Wendy and I as we're doing. Wendy's going to present to us, and if you want to put any questions in the chat bar, we'll try and answer as many of them at the end. But Wendy's very versed in looking at what you've already put in there and trying to address it as we go along. So we'll try to do what we can, and if not, we'll try and cover it all at the end of today's input. So we all know that adverse childhood experiences, trauma, are they're a global issue. They're everywhere we go. We know that they're happening to 1 in 5 children experiencing adversity in the US. We know around 60% of children have at least one adversity in the UK, and 24% of the general population have 5 or more ACEs. And we know what they are. We're going to talk about them today. We know they include things like abuse, neglect, household issues, poor health and outcomes, mental health issues, and so on and so forth. But our speaker today, Professor Wendy Ellis, has dedicated the whole of her career to changing that reality. And it's an honour on behalf of GLEFA and myself to introduce Professor Wendy Ellis to you, a leading expert in public health from the Milken Institute School of Public Health in George Washington University in the States. Wendy is going to talk to us about building community resilience. She's going to talk to us about a framework. Many of you will have used the pair of ACEs. I know I have, and the ACEs tree. That's Wendy and her team. And she's going to talk about her work, her groundbreaking work from across the world, and how that's impacted in different communities, not just in the US, but across the whole of the work, looking at social determinants of health and how we build systems that support families who are facing adversity. Her work has influenced national policy. It's inspired programs to support resilience, and we're really honoured for her to share her insights with us. today. So please join me in welcoming Professor Wendy Ellis. Over to you, Wendy. Thank you.
Well, good morning, good day, good afternoon, good evening, no matter where you're coming from across the globe. I'm super excited to be here, Justin, and I'm so glad that we were able to make this work on our calendars. So I'm going to share my screen. So this is the part where it doesn't, it takes me a moment here to get it set up, but it'll be worthwhile. To share our work that we've been doing for the last 10 years. I was sharing with Justin and Vi that actually this past month marks the 10-year anniversary for the Center for Community Resilience. And in that 10 years, we have literally traveled the globe. And it has been pioneers and supporters like yourself who have understood the connection between public health and ACEs, as well as law enforcement, housing, education, all of the things to create more trauma-informed environments. And so I'm really pleased today to be able to share with you what we've learned and what's emerging and how you can apply this to your work. So if you're not familiar with my work, I want to just let you know about the 4 areas that we focus on and how this work has grown over the last 10 years. Today, we're going to start with the Building Community Resilience Collaborative, which really is implementing the BCR process. So BCR, Building Community Resilience, it's a process. It was first introduced into the literature in 2017, but as individuals like yourselves across the globe started using it, what we began to understand is it's not a model, meaning something that is so set in stone that you do stepwise, but it's really a process. And I'll share some of the lessons learned from that process. But in the process of doing this, what we also learned is that equity and trauma are very closely aligned in the sense of where we have inequity, whether that is lower access to food or higher rates of disparity with regard to emotional abuse and things of that nature, then you have these higher levels of adversity. So if we're going to actually heal communities, we have to build access to supports. But those aren't always easy conversations to have. And so we created tools and a whole line of work that help advocates really begin to foster conversations around the truth of inequity so that we can begin to create solutions that stop those cycles and actually create cycles of prosperity and healing. From that, we put public health at the center with the Resilience Catalyst work that allows for public health to be at the center of pulling together multiple different sectors to address adversity, but also to help us begin to measure equity. And I'll talk about that in a bit. But regardless of your political context, regardless of your country, we are looking at this from a systems perspective. And when we begin to talk about systems, that means that we have to talk about the political context. Those things, legislation, bills, funding, appropriations, they actually have no borders. And so while much of the work that we've done in the policy lab at the Center for Community Resilience is rooted in the US context, political context, it's important to understand there are basic tenets that are important for us to think about. No matter what is your political structure, what are those political drivers that influence the context in which you're doing your work? So let's move to just looking overall the vast part of the network, just so that you can get an idea of both the size as well as the context in which this work has been done in the United States. So we have urban centers such as Dallas, Seattle, Portland, Oregon, Washington, D.C., but we also have rural counties such as Lee County, Iowa, very much a rural community where you would see disparity not only with regard to access to mental health care, but also disparity with regard to child psychologists, with regard to primary education, the quality of quality and affordable childcare. all of these things create, or the lack of access to those things create pressures on a household, which we know that increased household stress means that we have increased risk for childhood and community adversity. And so being in a position to look at the widespread political context, as well as what are the adversities that are being defined, has made this something that is been adapted easily across the globe. Now, I would love to say that I have been in all of these places where this work is done, but I haven't actually. But I think that's the beauty of the building community resilience process, is that people have been able to take the tools that we put on the website, take the lessons learned, use our webinars, and then adapt it to their context. And so that's what we've seen, is this viral almost approach to taking the Paravasis tree. I had no idea that Justin had used it. And every time that I travel somewhere, I find that there are people who didn't realize that the Paravasis tree was connected to the BCR work. But it is that universality of creating a language that everyone, regardless of your cultural context, can understand the intertwining of what individuals experience and the political or social environments that actually perpetuate what we see in practice. And so I do want to take a moment before we dive into the Paravasis tree to widen our lens. And that was the whole point of creating the Paravasis tree, and what we think of as trauma, and what we think of as what is happening in our communities, regardless of where we are in the world. So we see natural disasters, whether that's here in the US and that's hurricanes, or whether that's cyclones in the Pacific area, or whether that's heat waves in Europe, or whether that's drought in the Middle East, or the changing weather patterns that are creating changing migration patterns that are driving climate refugees across the globe. That's a set of traumas that are happening at the individual level, but also widespread throughout communities. When we think about war and terrorism, it's also the traumas that are being endured today, but if we do not address them, they will be passed on from generation to generation. And that generational transmission of trauma also includes generational poverty. And we'll unpack that in a little bit. But then we're also seeing across the globe weaponized xenophobia, the othering of so many different peoples, many of whom have been refugees from different countries in the context of some of these other disasters or traumas that I've just described. And then we have the political instability that is also attributed to the climate context, to the refugee crises, to generational poverty. So there's many different ways that when you're approaching someone, whether it's in law enforcement or in public health, there's so much more to the story than what you're seeing in that one contact. And so being able to zoom out to understand what is happening in my community, but also what has happened to this individual before they even set foot in my door, at my desk, or on my street is just as important to understand. And so that's what the Paravasis tree was really designed to do. It was created in a way that, to be honest with you, it came out of one afternoon of really struggling with how was I going to explain this complex relationship between average childhood experiences and the systemic inequities that we see. And I was going to present this to a group of social workers who were largely Spanish speaking, and my Spanish is not good, but who are really working on the ground in addressing many of the issues that were happening in the immigrant population here in Washington, D.C. And I said, well, being a former communicator myself, I know that pictures can tell 1,000 words. Pictures can unite us, and pictures also free us in feeling comfortable to tell a story, to weave a narrative. And so I created this tree as this analogy of leaves and the branches. Well, if we walk through a park, depending upon the time of year, here in Washington, D.C., you walk through a park and you see the trees are bare. There are no leaves. Well, you think, okay, it's autumn. But if it were a different time of year, you might suspect that that tree is dead. If you're only considering the weather and not necessarily the season of the year, but not necessarily what's in the soil, well, what sustains a tree when the leaves have fallen? What sustains a tree during the summer when the leaves are there? Well, that's all about the soil. It's also about the sun, but we rarely interrogate the content, the nutritional content of that soil that actually helps that tree thrive. And so similarly, when you look at the branches and the leaves on the Paravaceous tree, it may be easy to hear a narrative about physical or emotional neglect if you're taking a case report, but are you asking the more critical questions about if it's a child that you suspect neglect and abuse, and the parents seem to be withdrawn or the parents seem to be absent? Well, where are those children? Where are those parents? Are they working 3 jobs just to ensure that there's food on the table? If they're not showing up for parent-teacher conferences in schools, is that because they're literally exhausted after working 3 jobs? Is that neglect or is that an overburden? And so when we don't interrogate what's in the soil, we may be apt to solve the wrong problem. We may be apt to only address what we can see and not necessarily what's in the soil. And so that's what this tree is really meant to do, is to help us get into the habit of, when we hear a story of abuse or neglect, or we see these dysfunctions in our community, what's feeding that? What's missing in the soil that could help to both prevent as well as help heal along the way? And so that's the pair of aces framing in a nutshell, to really help us think about how environment and context play a key role in how individuals not only bounce back, but how we as systems actors can help a community bounce forward and thrive. And that is really our framing for resilience. Now, resilience means, coming from the dictionary, is actually a term that has been borrowed from physics, right? So when we talk about when we talk about resilience from the strict definition, it says that it's an object's ability to bounce back after injury or impact. So, sure, we can talk about a ball that we may squeeze in our hands, and its ability to bounce back to its original size is a measure of resilience. But do we really want to apply that to our children, to our families, our communities? Because it assumes that they're resilient only by the means by which they're able to somehow get back to a level that perhaps wasn't where we wanted them to start, wasn't the ideal starting point. But hey, they came back. They're still struggling to find food every day, and they're still working 2 or 3 jobs. But gosh darn, they are resilient because they were able to get right back out there. No, when we talk about resilience in the community sense, community resilience, we want to think about, yes, we're not going to be able to acknowledge that we're not going to be able to solve every or prevent every trauma. But our number one goal is prevention. That is public health, but also our collective responsibility from a systems perspective, regardless if you're education and business development and law enforcement, is you want to be able to strive to put in place those supports and resources so that not only are we bouncing back, but our communities have access to the resources that help them to bounce forward, to help our children thrive. That's the framing for community resilience. And that was the purpose of putting that Paravaceous tree, so that you could begin from step one to think about what's missing in that soil. Because yes, we want to prevent what's on the leaves and the branches, but don't we want so much more for our communities? Isn't that why we got into public service to begin with? So let's start framing that from a measurement perspective, because what is also revolutionary in the work that we're doing at Center for Community Resilience is we're not only helping people to understand these large concepts, but we're also giving a framing for measurement. There's an old saying, what gets measured is what gets done. And so it's not just about changing hearts and minds. Those things are important. They're necessary, but they're not sufficient. What is sufficient is for us to think through, if we're successful in building community resilience, it's so much more than the absence of adversity. It's actually those things that measure the effectiveness of the supports and buffers to produce indicators of thriving. And so those things, like on the branches and the leaves, can be things such as educational attainment, justice and juvenile justice involvement. Sure, we want to see that go down, but we also want to see our kids actually matriculating, actually being civic partners, being involved in their communities, not just merely not committing crimes. That's the lowest bar possible. So who are the partners that help us to create those differences with regard to what we see on the branches and the leaves? Well, that's when we get into the system's contribution to this community transformation. We oftentimes have to start with, if we want better outcomes in our schools, then we have to put our money where our mouth are, right? We have to spend in a way to produce the outcome that's desired. So it's not so much spending in juvenile justice as much as it's spending in education, so that we're giving our kids a pathway to success. It is about community policing that isn't just about public safety from a law and order perspective, but it's about the order piece. What is our role in being a community partner and being a point of safety for all of our residents? Whether that's a young child that just feels comfortable enough to come to the officer and just say, would you hold my hand while I walk to school today? Because my parents can't do it with me. Imagine that. You've got a big buddy now who's willing to walk to school with you. It's about knowing the names of the people in our community, about noticing when someone's not there, or recognizing that person that you see every day, getting to know their name, getting to know the shopkeepers. That's being a part of community that doesn't take away from the role of public safety. It actually enhances public safety because you are a community member who is trusted. The lack of access to mental health providers, unfortunately, has put an undue burden on our first responders. They are being asked to do so much more than merely triage and treat. They are doing the hard lift of many of our systems that have been left underfunded. And this is true throughout many of our countries. And so I am going to talk about one of the areas that we're looking at so that we can fill those gaps, so that individuals who are in public safety, individuals who are in public health, can actually do what is their job because they themselves are supported in a more systematic fashion. And the other part of this that we have to address, and this is where it's important to bring in our civic leaders, our business leaders, is that without access to economic mobility, you can't expect to have community stability. Those two go hand in hand. Wherever we have a lack of access to social and economic mobility, you have instability. And so giving people a means by which they can actually aspire is something that gives them a future to be invested in. It gives them hope. And I'll talk about that. You'll hear the themes of hope throughout all of this, because people have to believe that they're invested in, and they have to believe that there's a pathway out. And when you do that, you're actually building social capital, not just social cohesion, which is really what I was describing with regard to the police officer's relationship with community. How do we create community so that people are connected to one another? That reduces some of the feelings of isolation and depression in a community, but it also creates this cohesiveness where we see each other as individuals and not just as threats or strangers. When you have that kind of cohesiveness that's built, then you're actually beginning to build social capital. And why is that important? When people feel that they have the ability to organize and actually get the resources and advocate for the resources that they need, that they are a partner in this work, that's collective power. That is something that they are going to be equally invested in, just as we are invested as systems. And so this is why the trauma-informed piece is so important, because this is the part of breaking down individuals from being just units that we count, or communities is just territory that we cover, or buildings as just areas that we serve. This is really looking at the individuals and understanding my individual role in helping to prevent trauma, helping to embrace humanity, build power, build hope. And the only way to do that, to breaking the cycle of trauma, is to have equitable access to resources and supports that actually support resilience. So again, I always love pictures. And this was just also a simple way to help people understand the connection between trauma, however you define it for your community, and understanding that oftentimes what is underlying trauma is the lack of access to the supports, the resources, the buffers that help individuals heal, to break these cycles, and to get to resilience. So this, in combination with the Paravasis tree, helps us. The Paravasis tree, if you think about it, is really about what's the problem that we're trying to solve. And let's put it into terms that everyone, a narrative that everyone can understand, but also where individuals can see what is their role. And then reminding ourselves the first piece, the trauma. What's the problem that we're trying to solve? What's missing to create equity? And if we're successful, then we're going to get to community resilience. And how are we going to measure that? And so that gets us to the next part of this, which was the community resilience framework that I developed about midway through our work in implementing the BCR process. This was a way of really giving meat to the term community resilience. And I know many of you have heard it bandied around, and there are some that push back and say, well, I don't want to use the term resilient because communities have been described as resilient just because they have survived things that they should not have ever been exposed to. And I would say I absolutely agree with that. I don't use resilience in that way. I use resilience, community resilience, in a very intentional way to put the onus back on our systems, so that when we see things of generational poverty, that there's cycles and cycles and cycles, and we can predict where it's going to happen, and we can predict how it's going to happen and who it's going to happen to. Is that really about the people? Particularly if we can be so precise in predicting that. Because when we have cycles of poverty, we also have cycles of lower educational attainment. We also have cycles of higher contact rates with police and law enforcement, and higher rates of mental health issues. And if you look at the other column, you'll see lower quality housing, underfunded schools, lower access to social services, all the things that would help break those cycles are the things that are least likely to be available. And so that's why the community resilience framework came about, is a way to really understand the social determinants of health from a systems perspective. So when I went and researched how am I going to define community resilience and how am I going to help the people who are working on building community resilience understand the systems contribution, I went through the social determinant of health literature and really understood from that we have three systems that are most proximal to influencing the community environments that we see. And those community environments produce what are oftentimes described as social determinants that are ascribed to individuals as opposed to being described as outcomes and outputs of our systems. So those three systems were housing, education, law enforcement, and criminal justice. So let me explain the theory. If we look at housing, and oftentimes we know that housing has been described as one of the major social determinants of health, right? So if individuals don't have access to housing, they're less likely to be able to attain education success. They are also more likely to be justice involved, whether that's because they're homeless or because they are surfing and trying to figure out where can I stay each night, and they're doing what they can to eat every night, so that puts them in higher risk for bad decisions. But what if we looked at housing or access to housing as actually an outcome of our inability to work across systems to produce affordable housing, to produce living wages that individuals could actually have stable housing, to enforce code and zoning that would create quality and ensure safe housing for individuals? Then housing is actually, or access to housing is actually, that's less of a social determinant and that's a political determinant. That's a systemic determinant. So yes, it's important that individuals are housed, but it's also important that we're holding a report card to our housing development, to our city leaders who make these decisions around housing, not just for individuals to be able to get access to a voucher. The only way to stop that cycle is that we actually are saying, from a systems perspective, this is our job, this is our duty to provide a basic human need, a basic human asset. Similarly, educational attainment. What if we truly believe that every individual could learn? That just because a child has been justice involved by the time that they're 14, that doesn't mean we have to write that child off. We have to think and question ourselves, interrogate, why is it that our children are justice involved? Is there a lack of services to support perhaps the traumas that they have endured? Is there a lack of opportunity to connect the family to the resources that they need? If children are truly in an environment that is unsafe for them because of parents perhaps that have a substance abuse issue or a mental health issue that again is not being treated, why are we throwing the towel in on our children and making them responsible for the failures of both our systems and potentially of the adults that are around them that could create a better environment for them to succeed? So a child's inability to learn in the classroom, matriculate, that's on the adults. That's on our systems, not just on educators, but on clinicians, on social workers, and law enforcement. It's on all of us to support both that child as well as the family for what they need. Similarly, when we look at justice across the globe, who has access to redemption? We have to ask ourselves these critical questions. Why is it that depending upon your zip code or depending upon your neighborhood, if you have higher quality housing, higher household incomes, you typically have higher resourced schools and fewer justice involvement in children. Well, the difference is the investment that we've been willing to make in some people and the assumptions that we make in practice about those who have less access to those community investments. That's a systems issue. And so we really have to think about how our systems are contributing, how our practices across multiple systems are contributing to the community environments that we see. Because the more positive that we can invest, what we're doing, as I said earlier, what truly holds community resilience together isn't just about spending money, it's about fostering social cohesion. And when you have that social cohesion in your communities, you're also feeding social capital. And we have seen that where we are feeding those cycles, we're seeing reductions in individuals who are, particular children, who are justice involved. We're seeing increasing matriculation in elementary school children and high school children, not only just graduating from high school, but going on, whether that's trade schools, apprenticeships, or going on to college. But they're becoming viable individuals in their community. And at the heart of that was also investments in stabilizing households. That's not just housing, but that's also making sure that individuals had access, parents in particular, have access to the supports and resources they need to be healthy, but also to provide a healthy household for their children. So that's what community resilience is really about. When we break it down, when you say, I can't, it's too much to think about. It's three simple systems. And I bet each one of you on this webinar have connections, have relationships across these systems, but how are you working across those systems in a collective and intentional manner to change the community environment? Not just change people, but change the community environment by actually intentionally thinking about how your work is coordinated so that you are better supporting families. That's what is truly a blueprint for prevention as well as for advocacy. And so I know you've had a while to look at both the left and the right-hand side, so I won't spend much more time on the right-hand side because I've already kind of told you that story through the narrative. And the most important thing that I want to really stress is here in the US right now, we've got we've got some word problems. Um, but equity is not something that we should shy away from. It is a guiding principle. You can't be trauma informed if you're not focused on creating equity. And equity is something that we can measure as I've described it. And we can look at that particularly by place. So let's move on to the next part of this. When I talk about community resilience, as I gave you earlier, the Paravasis tree, we also have the resilience tree. The resilience tree helps you to begin to think across multiple systems that if we were successful in building community resilience, what would that success look like? And it's not just, again, the reduction of adversity, but it's the presence of supports and resources that actually help individuals bounce back. But as I said before, we want people to bounce forward and thrive. And so what does that thriving look like? Well, it could look like, safety and stability of neighborhoods. How many individuals are renting versus owning? What is the turnover rate? How long are residents staying in a building? The longer that people are able to stay together in a healthy environment, the more social cohesion you have in that environment, the more that children feel like they're protected, more that if you're a single mom, the more you feel protected and supported. And so thinking about the environments that do promote that social connectedness, that support health in individuals and families, and most importantly, produce social and economic mobility. Well, that's all rooted in a system that provides equitable and trauma-informed supports and systems. And so in the roots here, you see things that we can measure from a systems perspective that does have an impact in producing what's on those branches and the leaves, whether that's community-driven policing and policy, whether that's affordable housing, whether that's equity-based school financing, fair lending practices, integrated social services. It's all of those things. It's not just one because there's no silver bullet to any of this. So yes, systems change, community building, community resilience, it's messy. But like I say all the time, we got to say yes to the mess. It's yes, it is necessary and it will prove in the long term to be sufficient in helping us to change outcomes in our communities. So let's dive in a little bit more with regard to measurement, because I think it's really important before we talk about the process of building community resilience, that you're firmly grounded in how you would begin to measure this, because how you begin to measure this is how you will think about your role at the table, as well as who else needs to be there. So if we zoom out, what is the policy context in which you are operating and the particular variables that are going to impact the downstream things? So a lot of times what we have looked at when we talk about community health and community resilience have really stayed in that far right column. That column that talks about life expectancy, infant mortality, chronic disease, and that can be further downstream, right? But those things don't happen in a bubble. Those things don't happen just because an individual has food insecurity or we have higher justice involvement. Those things happen. Actually, if we continue going left, those things are more influenced by the policy, by the context that they're occurring in. So here in the US, and I know in many countries that are struggling with immigration, it's more likely that immigrants and people of color have access to poor quality housing and face discrimination and racism that leads to social disconnectedness and limits the ability for them to have social and economic mobility, but also the desirability of those neighborhoods. And we know from a policy perspective that those neighborhoods tend to be policed very differently. They also have differential access to education and the mental health supports that they need. And so when we think about those, as I said, if you skip to the SDOH category, if you skip to the health and social outcomes category, we've looked at, well, how do we address this for those individuals? Like I said, vouchers, justice, the programs that involved alternatives to justice and adjudication for juveniles. Those are great, but it's that middle column that changes the game, because that middle column says we're not just measuring this by the individuals. We're actually looking at these outcomes, particularly social determinants of health, as performance indicators of our systems. So if we want to change graduation rates, what are we doing in the policy context, in the policy column, to actually ensure that we can move the needle in certain areas? If we want to create housing stability, what are we doing in the policy context with regard to supportive housing, but also labor practice, so that individuals have the opportunity for economic mobility? So it's that piece of it that is complex and can seem extremely intimidating, but that's why you bring partners to the table. It's that mindset that the BCR process is really about. So I took all of this time. First off, we spent 35 minutes on the first part, and that's creating a shared understanding. What's the problem that we're trying to solve, and who else needs to be at the table? That's the most important part of the BCR process. Now, My communities that have done this, they say, wow, if you were able to do that in 38 minutes, that's record time. Because it took some of our communities 6 months, a process of 6 months to do that. But while they were doing that, creating the shared understanding, they were also creating a state of readiness or getting in a better feel for the state of readiness because they were bringing providers in, they were bringing systems actors in, they brought in the policy people to understand, well, what's the driver here? What's in the soil that helps us understand what we're seeing in community? And as I described, education, law enforcement, justice, public health, cross-sector partners are brought into this to help us understand the resource distribution, the community and political partnerships, and the opportunities for collaboration. But the most important part of this is community. So you'll notice in the middle there, there's the circle, the two arrows. And what that really connotes from a public health perspective is that this is a continuous improvement process. It's not just that we start with a shared understanding by ourselves. No, community is at the table. And we're vetting this across different sectors. So this is all happening. Again, it's messy, but it's necessary in order to get to solving problems that can be sustainable and sustain. And those two different things. Sustainable is financial sustainability. Sustain means that there's actually community buy-in as well as systems buy-in to the solution. So you're looking for a sustained support for this that is both financial as well as social. And you only get that if you're actually taking the time to have everyone buy into this, but also see their role. And that's why the measurement piece is so important, because of course, educators want to see improved indicators with regard to educational attainment. So there is something in it for them. There is something in it for the business community. There is something in this for law enforcement. That's why the measures matter, because it's not esoteric. It's also a system of accountability. And I really want to spend some time because this is probably the hardest part of the job. Anybody who works in community knows this, but it's the most important part of the job. And that is making sure that community is actually driving this. I am really excited. This time next year, I've written a chapter in the Oxford Handbook of Trauma-Informed Social Health. And the chapter is called Trauma-Informed Community-Based Research. And it really details the hard work that we've put into being very intentional with community partners to build networks that have survived a decade and are still going. And that is, the shared understanding process and why community is so important in all of these other quadrants is because it's helping you to identify the key issues, but also uncover these harmful narratives that we have created that actually are supported by policy. So how do we begin to undo policy that's not necessarily rooted in fact, but it's rooted in a narrative that oftentimes is aimed at blaming communities as opposed to understanding the mutual responsibility of systems? It helps us also understand people's experience with the system and identify specific policies and practices, but also opportunities for change, not just what's wrong, but what is our collective opportunity here to build something new that is effective. But it also helps us to gauge the levels of mistrust or trust that various sectors have and prioritize those issues. And most importantly, co-create solutions. So this is not something to gloss over. You really want to spend the time to build the community support, engage them, because that is also moving towards fostering social capital and building power. And power is really important at the community level because that's going to help with the sustainability, again, the community buy-in, but it also helps with regard to accountability from our systems, knowing that the report card is being held by your constituents as opposed to something that you can arbitrarily do. So given the notion, or given, the fact that community resilience is, or community engagement is so difficult, and it is the part that a lot of us will struggle with, our team created a new tool, and it's the Equitable Community Partnership Reflection Tool. In your kit, you also have a link to this tool, but it helps you to understand where you are, whether that's as an individual or organization on this spectrum of community participation. And so, are you at the area where you just don't even take any community input? These are the rules and this is what we're doing. Or are you at involve, where perhaps it is that we're consulting with community, we listen to their ideas, but then we come up with our own solutions? Or are we at collaborate or defer? It's important to know where you are on the spectrum, so that when you're going into community, the most important thing is you have these 5 qualities to the work that you're doing: shared understanding, collaborative decision-making, meaningful representation, reciprocal partnership, and respectful relationships. Understanding that being trauma-informed means that we are creating psychological, physical, and mental safety. You'll see how this tool is rooted in being trauma-informed, that you are creating environments of mutual respect, of reciprocity, but ultimately being collaborative and getting to the solutions that are going to stick. So I now want to talk about some specific examples of our work and how we've been able to do this over 10 years that are moving towards what we think are really the bedrock of how we move our communities to prosperity. So this last report, our latest report that we put out, was based on some work that we did in Cincinnati, and it was closing the wealth gap. Because at the end of the day, if we're going to truly stop cycles of abuse, neglect, and trauma, we have to put our communities on a stronger financial and social trajectory. And so understanding that it was about the wealth in health, let me say that again, wealth in health, meaning how do we help our communities achieve health that puts them on the pathway for greater economic mobility? That was, in every community that we've gone into, sure, there's issues with regard to police involvement. Sure, there's issues with regard to substance abuse. But when you really keep digging further and further down into the soil, you realize that it's the lack of economic mobility that is the underlying driver. And so our partners in Cincinnati worked with us to create this framework for action and measurement that does put our families on the pathway for social and economic mobility. And it understood that from a place-based perspective, to end cycles of trauma and address the root causes, we have to invest in place. It's not just the people and the practices, but those have to be invested in the people in our communities. And so creating these neighborhood hubs that have educational resources, co-location of, say, little grocery stores or pharmacies, mental health providers, community health workers, legal services, all co-located together, so it becomes a one-stop shop, a hub. Also fosters social cohesion. So people are getting their basic needs met, but also connecting to those things that will help them to thrive. This begins then to give them greater access to educational and community resources that then ultimately foster financial sustainability, the ability to start to build assets, whether that's buying a home or just merely being able to have a savings. those things that we know will create greater stability, but that in order to get to that foundation, it takes fundamental change in our practices and the access to services. And so this is what our partners in Cincinnati are working on. And we're working with a major philanthropy. I can't announce it yet, but we're working with a major philanthropy here in the US who wants to spread this type of framework and this type of collaboration that brings in economic interests, city leaders, philanthropy, social services, health workers, education, you name it, everyone together, all in order to begin to create more resilient communities. And so one of the things that we've done is actually change the way that we talk about the outcomes. We've talked about this now as a return on social and economic investments. So what are the economic and social returns on these investments? They're not separate. We know this intuitively, but oftentimes those of us that are in law enforcement and public health education, we've only spoken to this from a social perspective. And it's so important to understand that if we want to have these long-term durable networks that people from maybe a different sector wouldn't necessarily see themselves as our ally, we have to be able to talk in both languages. And so this framework actually connects the science of social determinants, the science of political science, the science of economic development, and connects the two in a narrative that is now seamless. So we understand that when we increase neighborhood likability and livability, we're increasing social cohesion. And guess what? That's related to increasing the percentage of households with access to banking services, to increase savings rates. So now I've suddenly brought bankers into a conversation about community resilience. But how many of our families that we see in these under-resourced communities don't even have access to a bank, don't have access to a means to, if they are able to save a little bit, it's going only in their mattress. So it's these kinds of things that help individuals feel engaged, connected, and invested in their own futures and in their own communities that are all supported in the literature, but very often we disconnect the outcomes. And so this framework, just as the pair of ACEs, just as the resilience tree, just as the community resilience framework, is really about let's take all of this science now and all of this measurement and turn it into action. What does that look like in your community? It could be some of these cash assistance plans. It could be 2-gen supports, meaning programs that not just focus on early childhood education, but also focus at the same time on the supports that the parents need. Perhaps that's job training so that they can move on to economic mobility. Maybe it's home visiting programs that also support social cohesion and connectivity in neighborhoods, but take an individual who is interested in social work and train them up as a community health worker, and they can work in their own community as home visitors. Or perhaps individuals who can be community health workers that are embedded in a legal services office that can connect individuals not just to the legal services that they need, but also some of the other social services or mental health supports that they need. It's thinking about all in and across all sectors, how we have these social supports connected to many of the services that we know our families and our children need. So one of the other things that we have in the United States was the Family First Act and the ARPA Act. And so there was a particular segment of that bill that really helped with workforce development. How do we spread trauma-informed training, knowledge, and practice across multiple sectors? And so in your country context, is there a mechanism by which you can encourage trauma-informed training and understanding and also measurement? What if we talk about trauma-informed training, what would be the expected outcomes that we could see? So let's get specific with regard to what is the return, whether that's an economic return or a social return. And ideally, you want to have both. So I just want to end this conversation with what I think is the most important part of this work, particularly in the global context that we're in right now. Whether it's what we're dealing with here in the US, but I think it's what we're dealing with across the globe. We have an epidemic of fear. Fear of the other, fear of each other, fear of the future, fear of our globe, fear of our leaders. And understanding that fear is an instinct, meaning it's an automatic response. If you heard a loud bang, you would immediately jump. You wouldn't even have to think about it. It just happens. It undermines social cohesion, promotes anxiety, depression, anger, and it leads to more fear. Itself is a trauma, and our response to fear can be traumatic. Hope, on the other hand, is a secondary emotion. I got up this morning and I made sure that I was early to checking in with Justin and the team for this because I have hope that what I'm doing today, despite everything that we read in the headlines, is going to make a difference. I am supported. I woke up in my own bed where I sleep every night. I saw my son before I started, walked my dog. I didn't worry about where my breakfast was coming from. I'm not even worried about my job right now. I have support. That's what community resilience looks like, which feeds my hope. I'm sure many of you today, regardless of what time it is in the globe where you are, you came here because you still have hope that you can make a difference, even in a culture of fear. So when we're talking about community resilience, at the end of the day, what we are considering, what we are building is a system that ensures that our communities have hope, even in the face of fear. They know that they have something that they can draw upon for protection, for stability, for support. So when we talk about community resilience, remember, we're not just talking about surviving, which is the bouncing back. We're talking about putting in hope that is measurable so that our communities can bounce forward and so they can thrive. So that's my hope for today's conversation, that we are all bouncing forward together for our communities. So thank you.
Wow, Wendy, thank you. That was amazing, and I can see already that there's an awful lot of positive stuff coming out. I was going to say, in our usual way, we've got lots of participants on. Can you say thank you to Wendy before we move on to questions and answers? I'd love to be in a room with you where we can all give you a proper clap, but we can't. So you can see lots of zooming all over the screen and comments over there. Wendy, we talked a lot about the global impact of your presentation today. We've got colleagues from Canada, England, the US, Kenya, Scotland, Wales, Australia, Ireland, the Netherlands, Sierra Leone, South Africa, and East Africa. And they're just the ones that have put in the chat bar. I am sure there's lots and lots more. And there's quite a few questions. So can I fire a few at you? Is that okay with
Of
with
course,
yourself?
but I want to do a special recognition there. I see Cynthia Greer. And Cynthia is from DC. She's been one of the original members of the BCR Collaborative here in Washington. So if anyone has a question for Cynthia about what it's like to implement this, particularly in higher ed, Cynthia, I'm going to call on you.
So is that your way of saying any hard questions to Cynthia? Okay. Um, can I start with a question from the UK? It's from Matt Merriam, and he says, I would love to hear any advice from Dr. Ellis about helping the community to develop that resilience when the civic structures, statutory ones here in the UK, are themselves experiencing the impact of trauma on a system level and are therefore themselves dysregulated.
Mhm. Yeah, that is, what is so common. Many of us who take on this work are wounded warriors ourselves. And so it is so important that we are putting in supports that are treating the front line first. You can't go out there and heal someone if you haven't dealt with your own traumas. And actually, it's great that Dr. Greer is on this call because that's actually how she began to implement this work at the university where she's located at Trinity Washington University. And one of the things that is a real concrete example is many of her students come from some of the higher areas of highest concentration of poverty and trauma, community violence and such. And they were going to train to become clinical social workers or eventually clinical psychologists and, working in human services. And yet they were bringing their own traumas to the classroom, which eventually meant that they were going to be bringing their own traumas to work with them. And so what Cynthia and her team, Dr. Greer and her team did was actually created a trauma, and their goal was becoming the first university to be trauma informed across all disciplines because of the understanding that that student population is coming with a higher burden of trauma to begin with. And so if they are seeking to become healers, they needed to be healed themselves. And so I do think that there are concrete examples of systems, particularly around education, that have done that. Dr. Greer did that with Trinity Washington here in Washington, D.C. We saw our partners with Trillium Care in Portland, Oregon, who did that for their teachers in one of the areas with the highest concentrations of poverty. They went through a very intensive training so that not only did the teachers feel like they were supported, but that they could support one another. Because many of the things that their students were coming into the classroom with regard to community violence or food instability or housing instability, let's face it, the teachers were dealing with that too. So it's thinking about, a microcosm of what are the supports that your team needs, because oftentimes those are there that reflects what your community needs as well.
Thanks, Wendy. That's really, really, really good. We next question. I'm going to try and keep them rolling a little bit. Was from the GLEFA Trauma Informed SIG, and the question was: with the work that you've undertaken around both communities and individual trauma, do you see a change in the original 10 ACEs? Do you think they'll change as time marches on?
I think, well, they already have. They have expanded quite critically, and understanding that while we have the understanding of the original 10 ACEs came from the Anda and Folletti study that was not a representative population, meaning they were upper or middle class white women from an obesity clinic, which means that they were insured, they were at least middle class, um, and they were coming in for a specific ailment. That's not representative of our population, even in California, let alone across the globe. But Dr. Roy Wade out of Philadelphia did an expanded ACEs study that was focused on an urban population of teenagers. And where we had in the classic ACEs, you have something like divorce. Well, how is divorce a trauma for families that have never been married? But, parental incarceration certainly is one. Community disruption, the experience of racism and discrimination. And I'm very proud to share this because when I first started doing this work, I did include racism, the experience of racism and discrimination as a childhood ACE. And I think it's fair to say this. Dr. Folletti did not agree with that at all. And Dr. Anda did. Well, just last year, I won the Folletti Award for ACEs prevention because of the scholarly work that we've done to help providers as well as clinicians and really the field writ large understand the expansiveness of how we define adverse childhood experiences. And it meant a lot to be recognized by Folletti, but it was also important that as a field, we step back and say that all trauma matters, all trauma, not just those that we define, but that we're stepping back to really understand what is traumatic to that community matters to that community. And that goes a long way. Number one, it's the first principle of being trauma informed. But I think, as advocates, as practitioners on the field, the more that we can write about that, the more that we can advocate for that is important because it is a matter of respect. And it's the only way that we're going to heal our communities is if we actually acknowledge the things that truly hurt them.
Absolutely. Thanks for that, Wendy. I know it's a question that keeps coming up. We've got a question, well, more of a comment really from Angie at the Green Sting Network in Kenya. She just said, we've built out the pair of ACEs here in East Africa in the last few years and have developed images that are used at the community level, but also within the Kenyan police for storytelling about how ACEs connect to structural issues. So I think we talked about, you at the beginning had no idea how global the ACEs tree was and the pair of ACEs was. I don't know what your thoughts are on that and where you can see it going in the future.
Yeah, so Ange, actually, there's a quote on my global map from her. I found out about her work. I think you reached out to me, in fact. This was pre-COVID, so at least 5 years ago. And it was the first time that I had even heard of someone just picking it up and using it. And of course, that then led me to do a little bit of investigating to figure out like where are other adaptations of this work. I am eagerly interested at this point in exploring opportunities that would allow for us to intentionally adapt the BCR process to different political contexts. So I'm in conversation with a couple of universities right now to see if there's opportunities to do visiting lectureships, workshops with different different entities. I am very interested because I do think that these four principles are important. But of course, the political context, policy, if you have a health minister in Rwanda versus some of the statutory policies that are in the UK, that should not be a barrier to doing this basic work. But I think the translation of how to do that has to happen side by side with people that are in country. And I'm eager to, seek out opportunities where we could do that together.
Yeah, and that global movement around hope we keep talking about, don't we? About how we all need to work together to bring trauma and ACEs and hope into the mainstream. I'm going to ask you just change it a little bit, but focusing on hope a little bit from a question from Kate Prue. Kate has said, developing a resilience program in New Hampshire, outside of mental health first aid training, which is funded by SAMSA, has been so challenging. It's difficult to get buy-in from anyone who isn't directly involved in human services. Can you, Wendy, or Cynthia, if we can unmute Cynthia, please, Vi, offer any advice on that? So maybe if you start, Wendy, then we'll ask Cynthia to come in as well.
Yeah, I mean, I think that it has been, I'll give you a very concrete example. In Oregon, the Trillium Services, they started in Portland. It was, they do mental health for adolescents, but they were very, very intentional on bringing in the community development folks, economic development folks. They brought in housing, they brought in, really thinking about all of the social determinants and who needed to be in the conversation. They are the ones that I actually started the measurement work. So how do we make this work relevant to those sectors that I spoke to? And I will just fast forward 10 years later, they were able to go to the state legislature and have invested into a statewide network of community resilience hubs. And what they've done is they started working with folks in DNR, so the Department of Natural Resources, because if if you know about Oregon, you know one of the greatest disasters that they face every year are wildfires. And where these wildfires take place, typically in communities that are under-resourced to begin with. So they took community resilience, knowing at the heart of it what they're talking about is this trauma-informed approach to helping communities be more socially and economically mobile. But they wisely partnered with people who were thinking about community resilience from a natural disaster perspective. They're not exclusive. They are very much closely entwined. And so the state was willing to put the investments into these community resilience hubs that work on a regular basis, co-location of this human and social services, but can flip the switch in time of disaster. And so it is not always going forward with just our mental health message, but it's thinking about who is invested in the areas of support that our communities need. And how do you begin to build an infrastructure? Because that's what we're really doing, is we're building an infrastructure. Remember, wildfires are something that are acute. They are where we hope that communities will bounce back. They will bounce back if they have access to the resources that they need in the time of disaster. But what you really want is this runway that we've begun to build that is going to help them to thrive. And so it's a both and, and so how do you begin to think about who else is invested and what creative partnerships that you can come up with so that, yeah, there's a bounce back component of this, but how are we also ensuring that they thrive?
Thank you, Wendy. Cynthia, did you want to come in on that?
Yes. Thank you for the opportunity to give my perspective as a partner with BCRA. Education is a major system. And one of the things that we discovered during our Trinity Washington University and our counseling program discovered was through some incidents with the housing issues at the time with uh, working with people who are experiencing homelessness, that our students who were getting graduate degrees did not have the full training and focus on systems and how to respond with people who are coming through systems, especially the mental health system. And so, one of the things that we did was, with the help of being a part of BCR, was revamping how we train and prepare our clinical people, because probably most people don't know that in our training process at the graduate level, you get one trauma course. And when we went back and looked at our curriculum, because this is something that we could do, we said, especially after, working with Dr. Ellis, we need to revamp how we prepare and train our counselors, that we really were not trauma informed and responsive. We were not teaching them how to be trauma informed and responsive. And so we have made great inroads. Our counseling, we reviewed, revamped all of our courses to make sure that they were trauma informed and responsive. We advanced into doing all kinds of social justice forums and perspectives. So even outside of the classroom, students were getting, this kind of perspective. And so, and then we got a grant from Kaiser, who was, supported our work in terms of being able to provide professional development for people who were already in counselor, who were already mental health professionals, but closing this silo approach that, we have mental health counselors, we have social workers, we have psychologists, but we don't talk to each other. There isn't a forum where people are learning and these professions are learning together. And that was the purpose of our grant, was to provide professional development for mental health professionals, no matter what perspective or what specific field, to be more trauma informed and responsive. So that is an example of taking education, reevaluating, revamping, repurposing according to what the needs are in terms of our communities.
Thanks, Cynthia. I think it's probably a global issue as well, exactly the same, because I know when we looked at our training needs analysis, I naturally assumed that trainee social workers and trainee police officers and trainee nurses and so on and so forth had quite an input on trauma-informed practice, and that wasn't the case across the board. And there had to be a lot of backpedaling to try and work that through. So I suspect it's similar across all the countries that are on the call today. Wendy, can I take it back to you for a sec? Matt
Sure.
Merriam has put in the chat. Our organisations are undoubtedly full of wounded workers. I also think there's a lot of truth in Sandra Bloom's parallel process work that suggests organisations experience trauma as a whole. How can a statutory body that has lived with the impact of chronic stress caused by, example, funding deficits, have the capacity to make the changes in the policy needed for community resilience? How do we help entire systems and organisations move into a window of tolerance? Happy for thoughts from anyone.
Yeah, that's why systems change is so important. I will give you a very concrete example of uncovering some of the systems policies that have impacted policing here in Washington, D.C. About 6 years ago, we launched a study that really wanted to look at community policing as a source of stressor. And that came actually out of a conversation with a group of physicians at Trinity or Unity Healthcare. So Unity Healthcare is in the more impoverished part of the city, and they were wanting to address higher, heart disease, diabetes, and infant mortality and maternal mortality. And so, immediately they went to this idea of, well, what if we did a farmer's market in the parking lot once a week? We could do, we could hire a nutritionist to be in the grocery store. We could help our clients think about healthy eating and physical activity. And I was like, hey guys, those are all great solutions or ideas. But how about we step back a moment and start to ask your clients, your patients, like, what do they feel like is their greatest impediment to being healthy and thriving in their community? And so I had the opportunity to sit in their patient rooms and interview individuals. They were supposed to be like 5-10 minute interviews. And I asked one question. And that one question was, what do you identify as your greatest barrier to health? And there was actually a follow-up question of, and what do you think is the greatest opportunity you have to improve your health? We never got around to that second question because, first off, each one of these interviews averaged about a half hour. Thankfully, I had a social worker who was standing by, because you never know what happens when you do these interviews. And what we found was two things that were really important. The first one, the number one driver of what they felt were their community health issues, were related to community policing, interactions with police in that neighborhood. And the second one, every woman, I did 63 interviews. Every woman that I interviewed described their history of sexual assault, being assaulted, whether that was by a family member, intimate partner, someone in the community, every one of those women. So what would a nutritionist do? What good would a nutritionist do? What good would a farmer's market do if you're not balancing these two big issues? Number one, people are coming in with this trauma that no one's measuring for, no one's asking about. And there's two levels of trauma. There's the historical trauma, And then there's the present day trauma. I interviewed one woman who it was the anniversary of her son's death by police. He was shot and killed by police. And I didn't know that. I didn't know that was going to come up. And I myself am trying very hard to not be triggered, but my humanity was coming in. As a researcher, I was like, it's more important that I'm a human being in this interaction than a researcher. And so it was understanding what are the true drivers, and then what can we do about that? And so I went to Metropolitan Police here thinking the door will be closed, but I thought, let's just try. We partnered with Kenny Barnes and the local Rotary here, and we actually launched a study that had Metropolitan Police and our youth. And so it was understanding, because when we went to the police and we talked to them, they said, we've been trying to figure out how we can have better relationships with our community members, but we just don't know where to start. So we would love to have a series of conversations. And if you can find youth who are willing to get to a point where they could sit side by side with us and have a conversation. So, well, that's going to be building trust, both in me and then ultimately in you, to have the ability to get them sit down. But in the process of this, we learned about one practice that was happening with police practice. It wasn't about abuse. It wasn't about, use of force. It was about how our police officers are rotated, what we consider high hazard duty. And so think about this. You have a city that's divided into 7 wards, and Ward 7 and 8 were considered the high hazard duty. What does that tell you mentally when you're going out and you're on that rotation? That's already put a narrative in your head. I just want to come home every night. And that's exactly what we're hearing from them. So you're being told that you're rotating into a high hazard area and you're going to have your guard up. And the way that they do it for equity is that they only rotate in. So you rotate out of your ward based on seniority and also time. So typically they would be rotating maybe 90 days at a time. So you're not, you want to get through your 90 days, you're on guard, and you're not there to form any relationships, any meaningful relationships. You're there to get through your 90 days. So that impacts practice. So when you think about, the trauma that's happening mentally already for individuals who are working on high stress jobs, and then the narrative that they're being told informs the practice that they put on the street. And so what if we actually changed how officers rotate, or maybe don't rotate, and how we changed, how we compensate individuals who, if we see that there's higher risk or there's higher need, perhaps the higher risk is due to we're not giving people the time that they need to actually form the relationships. So maybe that becomes you get higher compensated, not because it's higher risk, but because there's a different level of policing that's necessary, a level that's more about building relationships. And so those are the types of, when we think about how our systems actually perpetuate the outcomes, the interactions in communities, particularly with regard to policing, that was a huge aha moment for me, because I had no idea, number one, internally, how that staffing happens across communities, and also how that staffing, how the way that's communicated then affects how they interact, but also the short-term mentality of, I don't need to get to know anybody. I just need to get through my shift.
Thank you, Wendy. That kind of links us nicely into the next question. Throughout the chat, there's an awful lot of people from all over the world talking about some of the great work they're doing around trauma-informed practice and the training within their own organisations and the input around raising awareness and so on. I know Andrew Fee has raised a question. He says, with a history of working with young people in the criminal justice system, I'm now in a role where I deal with antisocial behaviour for a local district council. I know how the impact of ACEs can have such a negative impact on our youth, and without the correct early intervention services, we're always going to struggle to make a difference. My question to you is, how do I go back to my superiors and explain the importance of early intervention, where historically we haven't provided that kind of support as an organisation before. And I think that's probably a frustration felt not just within the UK, but also globally as well, around how do we prioritise early intervention, or at least get it on the radar for some people.
Yeah, I think this is where that relationship between education and law enforcement really could be strongest, because you're making both a social as well as an economic argument for investment and changing. It's not just about early intervention. Let's face it, the last decade has just been incredibly stressful for our young people. Well, first, it was, global terrorism with 9/11. And then it was the COVID. Now we've got the rise of fascism, not just in the US, but across the globe. And so and also let's not even begin to go into the impact of social media. All of these things have created stunted growth, emotional growth, social growth for our children, behavioral disorders, learning disorders. And we know that those kids that are at higher risk for learning disorders, behavioral disorders, wind up, rather than having the treatment that they need in an educational setting or clinical setting, wind up in our criminal justice system. Here in the US, our criminal justice system is the number one provider of mental health services, and that's both for the juveniles as well as for adults. And that's because we're missing our opportunity for prevention in the education realm, where we absolutely have the greatest, we should have the greatest priority, because this is putting our kids on a trajectory that they're going to actually return that investment by being invested in our community. So we're losing our children in their most productive years, 18 to 24, when they could be in the labor force, because they're somehow caught up in a justice system because of our systems of failing to address what was needed with regards to social and emotional health. And so I think, it's not just justice systems or police systems saying we've got to prevent this. It's saying, where's the choke point here? And the choke point is really an early childhood education as well as secondary education. We have so many opportunities that we're missing to catch these kids. We can't prevent everything, but we can certainly adequately address some of these issues so that they stay in community and can be productive. So I would suggest bringing your education leaders into this, because they certainly would, say, we need the help. I'm not expecting teachers to be social workers or health or behavioral health specialists, but they certainly should be supported in their work.
It just reminds me, Wendy, of a conversation from with the University of Birmingham here in England, where we talked a lot about the 21st century public servant, and it was all about how different public workers need to work closer together around common problems. Because if we don't, the business case is that we will all eventually not have enough money to do it. So actually, we need to blur the lines a little bit in order to help each other out. It's on the website there if colleagues are interested, under the 21st century public servant. There's just as an aside, in the chat bar, lots of people have put lots of links to lots of documents that colleagues will probably find really useful. And this one's from Joanne Hopkins from Wales. It says, "What an amazing conversation. Can I just add, in our work in Wales on understanding racial trauma better? Taking your leadership, Wendy, we decided we needed to understand better how racism and discrimination is experienced as adversity and trauma, and then what we need to know to ensure we are intersectional in our approach to being trauma informed," with a PDF attached. So it's that global piece again, isn't it? Taking the work whether you're all doing in the States and then bringing it in this case into Wales. I'm going to there's a couple of other people, lots of resources on there. So, and I know Jane Pearson from the University of Lancashire has mentioned the word to David Best as well around addiction and recovery, and said there's a lot of crossovers between addiction and recovery and your work as well, Wendy. So, on behalf of LEFA, I'm going to try and bring everything to a close. Wendy and Cynthia, I know you got dragged in at last minute, so thank you for for getting involved. It's a big thank you. I know that everyone on the call is going to want to say thank you as well, in the usual way. But I also want to say a big thank you to Vi and Maya, who have made the webinar, the Zoom webinar happen. They've put an awful lot of hard work behind the scenes to make sure that the system didn't crash and so on. So thank you to Maya and Vi for making that happen for us. And just a reminder to everybody, really, we do have the GLEFA Special Interest Group on trauma-informed practice. You will get a feedback email, and within that, you'll also get the ability to look at, if you want to become part of the Special Interest Group, you'll be able to do that as well. Please, if you get the chance, have a look at the GLEFA website. We'd be more than happy for you to join. This should be about a global movement. We've talked a lot about hope and developing trauma-informed practice together. So we all need to work together upon that. And hopefully I'll see lots of you at the LEPH conference next year in Leeds here in the UK. We will do a recording. We will get it uploaded for colleagues that haven't been able to join us today, but I still want to. And I've just been blown away by how many people from all over the world have come today. It's made to make this happen for us. So thank you to everybody. Enjoy the rest of your day, whatever it looks like. Thank you, Wendy. Thank you, Cynthia.
Thank you.
Thank you.
Thank you, Dr. Wendy. Great from New Jersey here. Thank you so much.
Thank you.
Thank you so much to everybody. We really appreciate you.
Wendy, will these slides be available for us?
Yes, I'm going to make them available afterwards.
Yeah, we'll send them out to you when we send the feedback out. So you should get the slides as well.
Thank you so much.
I think everyone as they're leaving, Wendy's saying thank you.
I really appreciate this, and hopefully I'll see everyone in Leeds in September.
Thank you so much.
Absolutely.